Yeah, the idea of the study started on January 2022 when we had the disposal of these new monoclonal antibodies for COVID-19, and we started to employ them a lot on our patients, and we observed a reduction on the mortality of lymphoma patients. So we had previous collection of all cases of COVID-19 among our patients in our registry. So we started direct comparison between the patients we enrolled, and we could administrate monoclonal antibodies and try to focus and to pick up which were the differences in the two groups of patients and if there was an impact of this kind of treatment in their general outcome. Of course, our expertise grew up a lot more in comparison to the start of the pandemic. So we had properly recognized the symptoms, and healthcare was immediately active for these patients in particular. I always say to the new patients that our patients was always instructed to wear masks and DPI to better isolate themselves from possible infections, because as you know, all patients with lymphoma have an immune compromission. So we started to collect these patients and outline which were the factors involved in their different outcome according to the lymphoid malignancies, their comorbidity, and their disease status. And we observed a decreasing trend of mortality from the start of the pandemic, mostly we think because of the vaccination that was generally administered to all our patients. And we had many more compounds at disposal to intervene with this disease. And another possible variant that we did not include in our study could be the COVID variants, because they were thought to be less infective, more infective, but less life-threatening variants. Yeah, we observed in a sub-analysis, we observed that the patients that were most benefited from the monoclonal antibodies were the patients who completed their vaccination schedule, so that received at least 3 doses of vaccine at time of reporting. And we included these patients as we observed that the factor most involved in the death of these patients during the COVID-19 infection was requiring oxygen support and a need of hospitalization due to symptoms of COVID-19. And we observed that with in vaccinated patients, all these risk factors were less present, so that vaccination had a protective impact on the lymphoma patients, and plus the monoclonal antibodies could further increase this response against the COVID. Yeah, we think that our most important finding is the evidence of two risk factors linked to the hematological disease, which were previous exposure to bendamustine and the presence of active hematological disease. And with active hematological disease, we consider all patients with present disease during COVID-19 or with undergoing treatment at the time of COVID-19. And we observed at the beginning of the pandemic in the lymphoid malignancies, bendamustine was supposed to be life-threatening in these patients, but in some subsets of patients, the therapeutic scenario is quite narrow. So bendamustine represents a good opportunity for these patients in order to eradicate hematological disease. So we observed from real life some patients performed anyway bendamustine, and we observed that the mortality was very high in this subgroup of patients. So if not it cannot be not recommended in certain contexts, but requires more attention than other therapeutic schemes. And the second factor was the active hematological disease, because all patients with presence of lymphoid malignancy were most at risk than patients with still lymphopenia, for example, but with complete response after treatment. Yeah, we think that our study has several limitations, but it gives an interesting perspective in that fragment of pandemic, and it invites the clinicians and the hematologists to pay attention to certain settings in which, even if the mortality of COVID-19 is not anymore the same as the flu of the pandemic, we require some attention and to promptly be active against COVID-19.